this recap for CML, which is very important. And CML has to be defined with peripheral blood smear with a high WBC count with Philadelphia chromosome positive with blast less than 10%. Now, these are myelocytes and metamyelocytes, and these are not considered blast. Whereas you can see over here, this is a myeloblast. Okay, and even this is a myeloblast. And you need to have at least like a few blasts, but it has to be less than 10. If it's between 10 to 20, it's in the accelerated phase. And if it's beyond 20, it's blast phase. And blast phase is supposed to be treated very aggressively. So myeloid stem cells come from myeloblast, which is CD34 positive, and this can be quantified flow cytometry. And greater than 20% is diagnostic for AML. Now, AML is greater than 20%, CML less than 10%. CD33 will be positive in early primitive stages and CD117 in very early stages. And the band forms and neutrophils are positive in CML. Most of these are MPO positive and less than 10% blast, greater than 20% blast. With Philadelphia chromosome positive is CML in blast crisis. Without a Philadelphia chromosome positive is AML with its own cytogenic abnormalities. Now, CML is managed based on response definitions, and the goal is to get a complete hematological response within like 1 year of starting treatment, and then a complete cytogenic response. A major molecular response is where we maintain the patient. This is the maintenance MM. And you can have a deep molecular response and a deep molecular response 5. So an easy way to think of it is complete hematological responses. There are no elevated WBCs greater than 10,000. Cytogenic responses, the BCR ABL is Philadelphia chromosome is less than the cutoff criteria. The major molecular response of 0.1 is MR3 or 1 divided by 10 to the power 3, 1 divided by 10 to the power 4 of IS, the International Standard Scale, is called MR4. And MR5 is 1 by 10 to the power 5. MR4.5 also is there. So basically, the main thing is when you start treatment to get a complete cytogenic response and maintain a molecular response and deepen the molecular response with an MRD of 10 to the power minus 5. And then you could like pull off the treatment and just do monitoring, or you could continue the treatment. CML patients should be like assessed with the SOCAL score, which you can remember as SOKAL, SOCAL, with a large spleen size, old age, the count if platelets are high, anemia, and leukocytosis. Because if any of these SOCAL parameters are dysregulated, you'd want to go for a second generation uh, TKI. Okay, and if it's in blast crisis, obviously we will go for ALL type of treatment. But in CML, you have various TKIs. Now, Dasatinib, Imatinib is the gold standard, which we give 400 milligrams, and it's a TKI inhibitor. Now, how to choose which TKI? All of these block BCR-ABL. Okay. Imatinib blocks the BCR-ABL. Along with that, it blocks PDGFR and c-KIT. Dasatinib blocks BCR-ABL both in the active and inactive state. So, Imatinib blocks it only in the inactive state. Dasatinib blocks PDGFR and it blocks this SRC. SRCG. SRC is another component of the TKI tyrosine kinase domain. Imatinib is uh, given 400 milligrams OD and takes about 12 months to reach a major molecular response or 10 to the power minus 3 or 0.01 IS. 60% patients on imatinib have edema, cramps. In 45%, 50% have nausea. 30% have rash and cytopenias as in 10 to 20%. Imatinib works very well. It's cheap and it's well studied. It has a safe long-term profile, and it has at 8 years, 92% patients had no progression, and 85% had an OS 50% in 5 years. Okay, and uh, imatinib in T315 mutation, and imatinib is not used when major response or quick response is needed. If you need a quick response with like an accelerated phase, or if there are like thrombocytopenia, so-called score is high, then we will go for second generation TKIs like dasatinib, nilotinib, or bosutinib. None of these can be used in the T13 in the T131 mutation. In that case, in T131 mutation, we have to go in for ponatinib. We don't have any choice because none of these will work. And if ponatinib, now the problem with ponatinib is it has a lot of side effects, cardiovascular side effects. And uh, let's just go one by one. Dasatinib, you can think of it like dasatinib will take 6 to 9 months to major molecular response. It's almost half the time of imatinib, but causes pleural effusion in 20 to 35%. It causes myelosuppression and it causes diarrhea, but pleural effusion is very predominant, and you should avoid dasatinib in dyspneic patients with COPD. Anything with D, dyspnea, you should try and avoid dasatinib. Um, Choose it in high risk CML, if there's CNS involvement or need for Dasatinib is the drug to go to. Nilotinib is another one which takes about 6 months to, get response. It does not have an SRC activity. But nilotinib causes QT prolongation, hyperglycemia, and dyslipidemia and rash. Nilotinib has got a good response. You can use it in young patients, but you should avoid nilotinib in metabolic syndrome like coronary artery disease, diabetes, or prolonged QT intervals. And if you do a NGS Y253H mutation, nilotinib doesn't work. Bosutinib is again second generation. It causes like a lot of diarrhea. Again, 80% is like very diarrhea prone. So what we do is 400 to 500 milligrams OD. The dose we can slowly down titrate the bosutinib dose. Ponatinib is a pan BCR-ABL inhibitor and is useful in T315 activation. Ponatinib, we give 45 milligrams OD. Well, ponatinib causes hypertension, pancreatitis, and arterial thrombosis in coronary artery disease. So if you have like T135 mutation, previously ponatinib was the only choice, but now we have something else called asciminib, and asciminib is the latest one with um, it's a stamp inhibitor, specifically targets ABL myristoyl pocket and does not touch the TKI, whereas ponatinib is a pan, TKI inhibitor. And ponatinib and all these drugs, we start at the high dose until we get response, and then you can almost drop the dose by half, including imatinib, which is 400. Bosutinib also causes so much diarrhea that you cannot treat them comfortably. Therefore, we start bosutinib at recommended 500 milligrams per day and then drop it to 300 and then to 200 after attaining major molecular response. That's after about 12 months. Okay. Now, uh, now we get a complete hematological response or major molecular response. But what's the practical approach? When we first get the CML patient, we do CBCs and we see the BCR ABL, and at 3 months, we should see some response, partial cytogenic response. And at 6 months, we should see for a BCR ABL at least less than 10% at 3 months. But if it isn't like less than 10% at 3 months, then we call it inadequate or partial cytogenic response, and we continue it. Okay. And at even if it doesn't come to less than 10 and it's greater than 10, then consider changing Imatinib or your second generation. Check for T135 mutation or try sometimes to even increase the dose. Check for compliance of the patient because a lot of CML is non-compliant. And BCR-AB, BCR-ABL is less than 10 is an optimal response at about 6 months. Okay. And at 12 months, BCR-ABL should be less than 1% for most patients. Or you should have a complete cytogenic response that's less than 1%. And then you go to 0.1%, which is major molecular response. 0.001 MMR, major molecular response, 4 MMR5. Okay, that's the IS, the International Standardized Scale, because BCR ABL by ABL has to be checked in standardized scale format. That's another discussion. But it's very important to know that if there is treatment failure, then you change it and escalate to either Dasatinib, Bosutinib, Ponatinib, Nilotinib, and Asciminib and maintain them in remission. So, good luck treating CML.